Pricing transparency. I've seen a couple articles here of late where there's still a lot of hospitals, hundreds of them actually, that are out of compliance with providing, the appropriate pricing information. I don't know how much the general public is really engaging those sites. I think depending on their situation, probably some a lot more than others, but seems to continue to be a topic.
Yeah, I think if I separate CMS from slapping our hands and telling us we're not doing it right, from the patient who doesn't even know what you're talking about. When we talk about patient and community outreach, we've got to change our words. We need to explain to them, you need an estimate on the MRI you're going to be having. Here's how you do it. 1, 2, 3. Everybody can get public ads. I've done it. I know you can. And the radio stations, the TV stations, they do that all the time. But we're so busy telling them about our diabetic clinic that we forgot to tell them about, hey, do you have questions about your bill? Here's how you do that. Or you don't know what's going to happen with the charge for your colonoscopy? We have help for you. I have yet to see that. I know all about my diabetes education, know that. Yeah, I got that down. But nobody's telling them how to access. So then we get frustrated, right? We put all this money in and nobody's even using it. They don't even know how to use it because you haven't taught them how. And then one person told me, well, you have to know how to get into your Epic and you got to drop down. I went, seriously? You made it that hard? No wonder I'm not using it.
Yeah.
So I think, when we did this at the Alabama HFMA, we had 3 great faculty from the Alabama chapter talk about it, and they were frustrated that people weren't using it. So then we talked about, did you do community outreach? Did you tell them? And I mean ABC. We talk like everybody's in our industry. So I think as a country, if we did more of that, we would have patients more willing to do it and understand what a gift it is. I don't think anybody has a clue it's even there. And we've made it just a tad bit difficult to access it. Boy, and of course, that's part of the regs that says
yeah, for sure. Dave, I've been to a couple events already this year, and one of the topics that has come up a lot is, and we touched on this a little bit earlier, but just the whole topic of employee engagement. This great resignation, healthcare is certainly not exempt from that. As it relates to the non-clinical employees of a health system, how some hospitals are losing some good resources, some good people, and employee engagement and finding and keeping good people is as much of a challenge as it's ever been. Has that been a topic of conversation at some of the events that you've attended?
Yeah, very much so. And it's tough because the old way of doing business is just not going to be that way anymore. I really think we should talk more about our success stories with the remote, with the you could do 2 days, 3 days. I love the hospital. There was upstate New York, and they were talking about how they've eliminated an entire building, not paying rent on it anymore, and people are sharing office space. And then I'd love to have a rev cycle leader at one of our boot camps just recently. She talked about productivity is much higher than it ever was, but the organization doesn't want them to stay at home because not everybody can do it, so therefore they don't get to do it. And she said, I've got really unhappy employees. And I thought, what did we miss in the last 2 years?
Yeah.
That we have got to be that flex or they're going to leave us. I mean, we are kind of a little high stress jobs.
Sure.
So how are you going to keep your talent?
Yeah.
And salary is only so much. And then it's like, I've got another employer ready to take me because I've got this good experience and they'll let me work from home the whole time. Done. I'm gone.
Yeah. Yeah.
And I just hate to see that. I was a little disheartened to hear that director tell me that. I talked to her a little bit afterwards and I said, do you want to talk to me? But we can think of some way, because her employees are highly unhappy. And, we don't need that. We learned a better way. We just have to let go of some of the thumbs down thing. We got to do better.
That's right. Being here in Georgia, in the Atlanta area, I've heard some of the hospitals in some of the more outlying rural areas talk about the benefit now of being able to expand their reach, right? They can now pull resources without having them have to move to their location. They can pull resources from the Atlanta metropolitan area where maybe they've got a larger labor pool for some of those skill sets. The challenge seems to be the gap between what maybe they historically have paid a person in that role versus what hiring someone from a more highly populated market would now cost them. But it's worth it. I mean, if if your alternative is you're not going to have those resources and you might have to run the risk of outsourcing them or what, not that that's a problem, but if the option is to outsource it, pay that person a little bit more. I think you're going to find that you get a great skill level and great productivity, and it'll probably really help you in the long run. So I think there needs to be a shift in mindset about, like you said.
I totally agree. I've worked in a rural hospital. I got to hire 80 people for 20 years. And if I could have offered anything, I would have offered, please let me get some talent. Not that they weren't great people, but they never heard of Medicare. They don't know how to run one of my speakers at the boot camp. She's going to talk about the challenges of AI, which if I hear that word again, I'm going to throw up. Yeah, AI's answer everything. And we forgot these are patients we're talking about. And she said, her biggest challenge, she didn't have any employees who know how to run all that stuff. And it's like, let's do the newest, greatest thing with the same pool of people. No wonder they're burning out and getting upset with us. What an interesting concept. I thought I never thought that way. But from rural Idaho, I would have never been able to find somebody who knew how to do that.
Sure.
Never.
No, sure. I understand. Absolutely. Talk about some of the other issues on the horizon for providers that they need to be looking out for. Anything else that is coming down the pike?
I'm glad you asked me that one, Bill. It made me think. Again, besides that side of service thing, which is going to kick us between the knees, it's called frontline revenue, but we're having Walmart open their own dock in the boxes. We're having Walgreens is doing theirs. It's called Village MD, and they just announced they're going to have 200 of those in their pharmacies, which you walk in and there'll be a dock in the box. There may be a mid-level, but they're going to do hearing aids, glasses, labs, x-rays. We're talking low level, but Walgreens, CVS Pharmacy is. Amazon did their own for their employees rather than work with hospitals or insurance companies. They said, we just do it ourselves. This is your outpatient revenue. And what have we learned with the pandemic? When we lose outpatient revenue, especially those surgeries, we are in a world of hurt. So we have to pay attention to I hate to say it, to our pricing. We got to compete directly with the ambulatory surgery centers.
Right.
And that's probably the hardest thing for everybody to understand. It's like, we have so many more costs than they do. Yeah, but to the patient, what's the charge? Okay, well, we have more costs. We got the greatest ER in the world. Yeah. What's the charge going to be for my carpal tunnel? We have got to be price competitive with the freestandings. And that is a conversation we don't do easily. Right. Because that is not the way we operate. I would think we're losing our front door revenue, our outpatient revenue, and we've got to be price competitive with the imaging centers and the ambulatory surgery centers. And as much as that just kind of grinds on me, because they don't have the overhead we do, they don't have the bad debt we do, because they don't have to take people. Right. They don't have ERs like we do. I know that. And you're still going to lose a business because they're sending them there because they're cheaper. That is a huge, boy, those CFOs, they might need a hug. They're going to need a hug. Put the mask on, but we'll do the COVID hug. Yeah.
I hear you. The other thing I would add, the other feedback I would add to this topic is I feel like providers for the last 18 to 24 months have been very tunnel visioned on this pandemic and managing through it and the day-to-day challenges that it brings. But I think it's going to be important long-term to be able to step back and really look at their business, the forest through the trees, and see, when they get back to some hopefully more consistently normal volumes and whatnot, and start to see that revenue flow, that they're prepared for it and that they're grabbing every bit of it that they're entitled to. I mean, there's nothing that I hate more, being on the vendor side for so many years, than seeing revenue that a hospital is entitled to that they're not recovering, right? And I think that's going to be so important moving forward. And so again, the point is, take some folks and just say, hey, step back from your day-to-day business and say, what are we doing right? What do we need to be doing better? But also don't hesitate to reach out to some of your peers in other facilities and other markets and say, tell me some things that you're doing that maybe we need to be looking more closely at. And
I think Bill couldn't agree more. We have just an example. I had this conversation just 2 days ago of urgent care versus ERs. We have the payers who have made it their mission to make sure we aren't paid for ER visits that aren't emergent. Remember the layman language, there's lawsuits going on, but I said to the hospital leaders, why don't you have a urgent care within your ER? You walk in, your medical triage, your urgent care, emergent care in the same space. Why aren't we doing that? Well, it just doesn't work. No, why aren't we doing that? Because when we don't do it, the payers do it to us.
Yep.
And we have griped about ER having non-ER patients. Well, why didn't you do this?
Yep.
Or another one that said, well, our urgent care is open from like till 7. So nobody have urgent care after 7.
Yeah.
Okay. Dumb as dirt. You have an ER that you could medically triage and send them 2 different ways. I've been in hospitals that have done that. And their patients are told right off the bat, now, this is not an emergent, you're always medical triage, don't get me wrong, but then it's like helping them understand that this one's going this way, 24 hours a day.
Yep.
Now, why are we whining? And
Right.
the bills are appropriate for where they are. So stuff like that, Bill, I'm like, get out of here, let's do this. Let's be as flexible as the competition is, the Amazons, the Walmarts, the CVS. Yep. Why aren't we that creative? We can be, we just get bogged down with the, we've always done it and woe is me. And that urgent ER story was one that came, I can tell you, I've seen it, but it was actually written up as an article that is, we need to re-educate the masses to stop using the ER. I kind of like the person who said, well, then we better have an alternative.
Sure.
And I went, yeah, we better have an alternative. And why are the hospitals letting these people do it? Again, there's urgent cares all over in your area. There are in mine, but they're only open so many hours. Why doesn't the hospital open for 24?
That's right. Yeah, good point.
It's exciting when you see what we can do instead of letting people do it to us.
For sure. A couple more topics and then we'll wrap it up. This has been great. I know how important it is and you talk about this all the time, how important it is for providers to wear the patient navigator hat to really help their patients understand everything that gets thrown at them. Anything you want to say specific to that other than just a friendly reminder to providers to look at it through the patient's lens?
You know, we talk about that a lot. I really like Joe Pfeiffer. He says it all the time for the HFMA National, be where the patient is, but we forgot to then be the patient. If you are the patient, this looks different. And, you know, I'm always amazed when I have to be a patient now, when I was in the ER and then with my family. I think a patient financial navigator, when I actually talk about it with people, I said, who helps your patient when they get a denial? You just send me a bill, tell me I have to pay it. Really? That's the strategy we do now, huh? It's so simple to say, we can meet where a patient is. They didn't ask to be sick, didn't ask to have their insurance pay so little, or no insurance, didn't ask to have their bill so high, and then they denied me? Who helps your patient navigate this? I think if anything else, Bill, when you said maybe it's time to step back and reevaluate after living through the worst of the last 2 years of COVID, where did we really fail our patient? And not with their diabetic education. Maybe we actually failed them in understanding the financial process. When I write articles, I always tell people, or our boot camps, I know I'm going to say words you've never heard of before. It's really okay for you to ask me what they mean, but most patients don't. You know, they don't ask what accountable care means or transparency means, or I love this one, value over volume. What does that mean to your patient? Right. So if we became their navigators, we would become the educators. We would be doing those 30-minute blurbs educating. Instead, it's pay the bill because your insurance denied. And I can tell you that firsthand from multiple facilities, which is pretty sad.
Yeah, yeah.
Be a navigator, dudes.
Yeah, absolutely. I think as professionals in the industry, we always forget that not everybody knows some of the lingo, some of the process that many of us in the industry are very, very familiar with. So we have to peel it back a little bit and make it as elementary as possible so that people really understand it. So Day, where can we see you in the coming months? You got some more boot camps and some more opportunities to present?
I have a bunch of HFMA chapters I'm having the privilege to teach at. So awesome. I don't want to forget any, so I wrote them down so I don't forget these. Mid-South this week is HFMA Mid-South regional meeting. If I can get on an airplane, we're kind of still playing with that. Yeah. Out New Mexico in March, Kansas in April. Wait a minute. Greater St. Louis in May, West Virginia in May. I'm trying to remember them all. If I forgot you, I'm sorry. But we've got Maryland coming, so lots of great chapters. I'm very blessed, and I'm very, very humble that I still get the opportunity to teach.
Well, and I will tell you, you're always a great draw, and people I think always leave your sessions feeling like they've learned something, but they also feel really kind of pumped up to get back at it and do whatever it is that they do even a little bit better. So
And by the way, Bill, when I teach, I'm a really good student. A lot of the stuff I'm sharing with you is because I sit and listen to other people, and then I go, how can we do that better?
Yeah.
I know that's the value of our professional association, is that we get to learn from each other. So I've done 40 plus years of this, and I'm still sitting in class with a yellow pad, writing up a storm, going, there's good stuff here. We need to make sure we're teaching it.
Yeah, if we think we've learned all there is to know about healthcare, we got a lot to learn, because it's changing every day. I mean, you know, as a professional, and not even on the provider side, I'm doing my darndest just to keep up with it all, and it's not easy. So I appreciate it so much. It's always so great to catch up with you. I wish you good health, and I hope that you continue to carry the banner for the healthcare industry, because you're one of the great advocates, and really just love having you as a friend, and look forward to many opportunities in 2022 to cross paths with you, and to collaborate and network.
Thank you, Mr. Bill. You are the best. And I love this. And I think everybody should appreciate when you just sit down and say, let's talk. I mean, not many of us do that. So Bill, your glass is always half full. That's why it's such a joy to be around you.
I appreciate your perspective. You know, I'd come over and share a cup of coffee or some Chobani yogurt with you if I lived a little closer.
I know. I had Chobani's this morning, so you know. The little flip chart thing.
I told you the flips are one of my favorite. What's your favorite?
They are the best.
What's your favorite flip flavor?
Oh, salted caramel.
Oh, okay.
Salted caramel. You get little pretzels, love me.
Peach cobbler for me.
I had that this morning.
There you go.
This is so funny.
You take care. We'll talk soon.
All right, everybody. Thanks so much. Thanks, Bill, for doing it.
Bye-bye.
Bye-bye.